Thank you. Thank you. And good morning, everyone. Thank you for making it bright and early in pediatric time, at least at 7 a.m. And even though I'm a pediatric urologist, but this talk and this topic really affects adult urologists because we know that most of the care of our patients from essentially 17 onwards go to you. And in the next 40 minutes, I'd like to go over what transition to adult care means, what are the models employed, what's happening in British Columbia, not just in urology, and really introduce the approach for the new LEDCOR Center for Adolescents and Transitional Urology, outlining our key objectives, services that we offer, and strategies for enhancing this experience for patients and families. I'd like to start off by going over what does it mean to be an adolescent? And in its most simple term, it's really the period between childhood and adulthood. But how we define it actually varies greatly based on timing and length, historically and between cultures. The simplest thing is age, 10 to 19 years. That's how the WHO defines it. There's also the biological aspect, start of puberty to full reproductive maturation. Then this is the social cultural aspect, like participation in rites of passage, educational milestones, or assuming like social responsibilities or taking over. Over the last, I would say 10 years, there's also been a shift on a more developmental approach where you look at things as a whole, physically, emotionally, and cognitively. This is just a brief overview of brain development. In the adolescent brain, the limbic system, which consists of the cerebrum, pons, and amygdala, so in the hindbrain, undergoes significant development and changes years ahead of the prefrontal cortex. That system plays an important role in determining rewards and punishment, processing emotional experience, and social information. Later on, towards the latter half of adolescence, termed emerging adulthood, the prefrontal cortex develops or catches up. And this is what happens when we increase self-regulation and the ability to weigh in the pros and cons looking forward to the future and what the consequences are. But this difference in development contributes in part to why adolescents may have more risk-taking behavior, such as reckless driving, smoking, drinking, as they may not have developed yet the cognitive control to resist these impulses or to pause and take kind of inventory of things and what are the consequences if I do this. So when I Google, what is the top 10 things in the adolescent mind, or, with Safe Search on, it goes like this, right? Nowhere in there is healthcare or health or personal health. And in fact, most of us in this room were hopefully healthy enough that was the last thing on our minds. But it's very different for patients that we see and transfer to adult care that are living with chronic issues and illnesses. At the same time, what happens is that for institutional reasons, patients graduate from children's at 17 years of age. So really, they're in the thick of all of these developmental changes. And what happens afterwards is also a big shift in how we deliver care from a pediatric model to an adult model. Pediatric-centered care, if you remember, and for the residents that rotate, the approach itself is quite different because we have to consider the family and the patient. When it comes to consents, for example, it's the parents that we talk to. Patients may not understand when they're so young, and it's hard for parents to let go of that responsibility. In terms of the quarterback of care, there's usually a pediatrician, and if they have many, many comorbidities, they go to these multidisciplinary clinics where we do our best to coordinate every appointment, every investigation, to go with what works best for this family. We even go on off days for us in the OR, and that's not just true for urology, but other services. And if they miss an appointment, there'll be many, 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 many phone calls from our office staff, from our nursing staff. But we know that it's very different in adult care, and it should be. I'm not saying that's what should be done. Patients are expected to be responsible, to show up in time for their appointment. They are the ones that make the decision now. The different specialties are in different silos, different offices, maybe across town or different cities. So they have to learn how to navigate through all of this. And this is the reality, and this is something that instead of changing the system, I think we can better prepare them for it with support. So it's no surprise then that no matter what specialty you look at, health outcomes deteriorate in adolescence. You know, the biggest urology example I can think of, I didn't put it here, it was kidney transplants. There was a review in 2000 in an American transplant center where 1 in 5 patients lost their allograft within first couple of years of transitioning to adult care. Same is true for liver transplant because of non-adherence and even death. In patients with rheumatologic diseases, a third of them have flare-ups within a year of transferring to adult care, requiring adult treatment or acute treatment. And for urologic contact spina bifida patients, that's where most of the urology literature is. A third of them, when they present to adult care, need some sort of intervention. That's not doing the regular Botox, but doing a cystoscopy, doing a revision for reconstruction. Then it comes down to, okay, well, how can we prepare them better? Some specialties like cystic fibrosis, one of the biggest lobby groups, the Cystic Fibrosis Foundation, mandates that an adult center be present when there is a large enough pediatric center of over 18 patients that they take care of because of a disease that is high mortality. Ours is different. Ours is low mortality, high morbidity, and quite chronic, but the same issues can still arise. So this area called transition to adult care has been evolving, developing across medicine. And the common misconception is that once I transfer the patient to adult care, then we're done, they're transitioned, right? But really, it is about preparing patients and families for that shift in healthcare responsibilities from parent to child, for advocating and navigating the different providers, all at the same time guiding them through the adolescent years. So it's not really more of a here you go, but more of a continuation, passing the baton. And it's very important for us to think about that development aspect of it. And that's probably why they no-show a lot to a clinic, or they don't refill their prescriptions, or they forget investigations. From a health standpoint, the ultimate goal is really to have good health outcomes, to keep them at the same health level or better, ideally, from when they leave the pediatric system. But overall, really, it's for them to integrate into adult life. That's kind of like the overarching idealistic goal. So with that, there's multiple different transition to adult care models. And these are the general themes, these 4 things. You can mix and match them. Right? So starting with the top left, is the program longitudinal? Does it span both pediatric and adult health systems? Or is it just all in the pediatric side and hope that that is enough to get them through and let them figure out the rest? Do they transfer from the pediatric hospital straight to the adult hospital? That's what most models are. But some actually go to an intermediate youth-only clinic, where the advantage is that they can be in a waiting room with their peers and, you know, see that they are not alone, that they're all alike, as opposed to the one patient in a 40-person waiting room of patients who are generally older. And then the least common is, do they stay in the pediatric hospital? That also exists. Then on the bottom left, do they go to one provider or one center, or do they go to different providers across the region? Most pediatric hospitals are centralized, versus there's way more adult hospitals located across any state or province. It makes sense for diseases that are very specific, that are very complex, like cystic fibrosis. Again, I quote that a lot, but also for congenital heart diseases, where there's a fellowship to take care of these patients now, if you go into adult cardiology. Then the last is it a disease-specific model where the preparation is done within the specialty that the main issue is for the patients? Or is it a generic model where they go to adolescent medicine or psychology to prepare them about what adolescence is, what challenge they may face, and what tools they have? When you have this many possibilities, it just tells us there's no ideal model. And what determines whether it works or not comes down to funding, expertise, and personnel, geography, the nature of the disease, insurance coverage, not as big here, but really big in the States. Those are the factors that kind of determine what would work best. And they might have to change too along the way. In urology, I picked out 3 examples of 3 very different models. The first one is in Indiana, where they do a lot of major reconstruction, and the pediatric urologist actually sees these patients and follows them at a youth clinic that is down the hall from it's in the pediatric hospital down the hall from the pediatric clinic. And you have a subset of your pediatric urologists that have obtained further training and definitely have interest. So they're termed congenitalists in the adult realm that take care of them. Then you have Children's Hospital of Alabama, where they have a very high prevalence of patients with spina bifida, and they take care of a lot of them. And the model they've done is from the pediatric multidisciplinary team of urologist, orthopedic surgeon, social worker, physio. When they graduate from pediatric care, they go into an adult rehab facility of the same complement of specialties. More resource intensive, right? Imagine having all of this bodies in one place at the same time. Then for Canadian context, and a different model is what they do at Sick Kids in Toronto and Sunnybrook Health Science Center in Toronto as well, but an adult hospital, where pre-transition preparation is done by the pediatric nurse practitioner. And then when patients turn about 18 or 19, that's the cutoff there. They have a virtual visit with the pediatric and adult urologist, and after 1 or 2 visits, they just go into adult care. So 3 very different things. In British Columbia, these are probably the most prominent examples of transition to adult care clinics. The rheumatology clinic, the Yard Clinic, is across the street from VGH. This is a joint clinic between pediatric rheumatology and adult rheumatology. This is a youth-only clinic, so that intermediary model. The rest are more pediatric hospital to adult healthcare system. And the longest running ones are the rheumatology clinic, cystic fibrosis, patch clinic, which is in St. Paul's, that's for congenital heart disease. And there's emerging ones over the last decade, diabetes and renal transplant as examples. The main thing about these clinics is they are multidisciplinary in nature, not just in the pediatric realm, but in the adult realm. They have a combination of nurses, pharmacists, and social workers within their clinic to do all of this. When we look at urology, what happens right now is patients are referred to adult urologists ad hoc as needed. And for us pediatric urologists, the mental gymnastics we do is, okay, well, what are the patient factors? What are their diagnosis? What is their anticipated need? Where do they live? Are they moving for university? Are they willing to travel? Do they have the means to? Are they motivated enough? Then there's also provider factors, like what are the adult urologists' expertise in an area? Are they willing to take over care for this patient? And between those, we try to decide who to refer patients to. In 2016, Dr. McNeely and Dr. Sharudi sent a 50-item online survey to graduates of BC Children's Spinal Cord Clinic. And I'm just going to show two responses from that survey. The first one being, what are their health concerns now that they are the emerging adult or adulthood phase of life? And the top three things are actually urology related: urinary incontinence, urinary tract infections, kidney or bladder stones. And I highlighted sexual dysfunction as well, because that is within our realm. And that is actually likely to be underreported in literature and is becoming more and more at the forefront of what we need to work on. During that same survey, they asked patients, what do they think about the statement? Overall, I was satisfied with measures in place to facilitate smooth transition from children's to adult healthcare. And many of them actually disagreed. And you can see they're highlighted in yellow. So the next thing we did was, okay, well, let's ask what the BC urologists think or feel like about transition. So last summer, we sent a survey inviting 60 adult urologists across the province when we had 40 respondents from this. We had a good representation across all health authorities, and every health authority actually, with the numbers shown inside the red circles. More than half or most of the respondents have actually been in clinical practice for over 10 years. And that just shows you, for us anyways, their opinions, and they're very likely to have seen these patients and taken care of them. 60% of the respondents have subspecialty or fellowship training, again, highlighting the expertise all around the province for urologic care. When we asked the urologist how many patients they see in their practice, the x-axis being number of respondents, you can see that most of the respondents actually had 10 or less, and very few had 31 plus patients in their practice. Again, highlighting the distribution of care for our patients happening right now. From this survey, we also took key lessons from it, and there's a lot of text. I'll walk you through it. One of the first things that popped up was our patients have a lot of records to review, and that means a lot more time for adult providers compared to the average clinic patients that they have to sort through. Our patients are also more complex, having had many surgeries and a lot of psychosocial issues that brings on with it compared to the average patient in their practice. Most feel like patients are not adequately prepared for the adult healthcare system. And most felt that maybe we should transition them later at 21 years, for example. Again, fitting with that developmental aspect of things when I mentioned at the beginning. And because we lack relevant clinical guidelines, evidence, we don't know really what's the best course, because we haven't really tracked these patients, not just in our province, but just across our field in general. The ability to discuss with pediatric urologists for advice was the most frequently used resource they had. Dr. McNeely alluded to, yes, Dr. Patterson.
Sorry to interrupt. The renal replacement pediatric population and the transplant population, they transition at age 25?
So
because they tend to hold on to those patients for a long time at children's.
So they hold on partly because if they are nearing transplant at, let's say, 18, 19, and they're getting worked up, then they hold on to them. And after transplant, they hold on to them for 2 years. Renal replacement, same idea. Off the top of my head, an example would be a 19-year-old that's just not ready for transplant, who's on hemodialysis, so they just get transitioned to whatever hemodialysis unit is closer to home. Yeah.
And then the second question is that there's obviously a concern about last case bias that's occurred here, because I would say most of these patients that I see I've got from the emergency, because they've come in because of non-compliance, and then I'm dealing with an absolute mess. Yeah. And then I take them over, and then I say, it's getting them back on track is so much work that I say, I'm going to invest in this patient because I don't want to deal with their stones like this again. Yes. And then I'm having conversations with, with you or Andrew, et cetera, to say, this is what's happened, and I get additional information.
Yes.
And then third is that with the patients that are transitioning, they have a lot of financial supports in terms of transportation and coverage of hotels and everything else when they're at the children's hospital, and when they're sent to the county hospital, they've got nothing. So like they really don't. They don't have, and so what's going to happen is that the Prince George patient is going to be in Prince George because the family do not have the financial resources to come down there. So the guys up there are having to deal with incredibly complicated patients that cannot get subspecialty care. Like even getting them down here to see Dr. Anderson or Dr. Nigro, et cetera, Dr. Kavanaugh is going to be a challenge because of financial issues. These patients, they don't come from high socioeconomic generally, in my experience.
Agreed. And all of those points are exactly what's been reported everywhere, right? Those are all the factors that are important. And it's not just one thing that you've highlighted many, not all of it, many of the issues, right? And that's what leads to poor outcomes, health-wise at least. Because it's not just if we change one thing, we'll make it better. We have to look at it as a whole. That's the big thing. And Dr. McNeely alluded to in the introduction that there's been many false starts. This is not a new initiative. There's been many trials, proposals, and the biggest difference now is really that with the work of our department leadership and Dr. Goldenberg, that we got donor-directed funding to establish this. We have to acknowledge that is the main thing in our already starved healthcare system. Where do you get the money? But at the same time, things have also changed from when the last push was. There's now increasing societal awareness for delivering equitable care. When we think about what's the spotlight on mental health services, or culturally sensitive healthcare delivery, or equity by region or geography, for example, and gender-affirming care, these are examples of populations or groups of patients that, have been on the sidelines for some time when it comes to funding and programs. Virtual care has also become more prevalent and accepted by providers and patients, especially since COVID. So that opens up a lot of possibilities for developing sort of regional type connections. And there's also been an expansion in number and scope of nurse practitioners in healthcare settings. And we see that with physician assistants as well, for example. So again, just trying to bolster the healthcare expertise and people. So when we were trying to craft what would this program ideally look like, there were a few things that we had to consider. So number one, we do not want to replace their primary care provider. The primary care provider is the quarterback for their care. That's where our system is designed to be. So we want to support the primary care provider as opposed to sidelining them. It happens enough in the pediatric realm when patients are complex. And it's very unfair for them. And I do not blame them when they suddenly get this big package of here are the health issues at age 17 or 18, and now it's on you. The other thing is that we want to encourage a program that is province-wide, where care, if appropriate, is delivered regionally. So we do not want all of them to come to VGH. We do not want all of them to come to St. Paul's. We want to utilize that expertise, that subspecialty trained urologists, and the ones that are willing, that I mentioned earlier, to take over care for these patients with support. And last but not least, we don't want to reinvent the wheel. There's actually a lot of existing resources in the community that patients can access, like Foundry VC is for mental health services for youth. We have for patients that need a primary care provider, there's been a bigger push. So there's a Health Connect registry that you can sign up for now. It's a wait list, but you can sign up for. We will help them find a primary care provider. Calling your local division of family practice is another example. And even for preconception counseling for patients with complex healthcare needs. There are clinics and MFM clinics at Surrey Memorial and BC Women's that have this. But again, knowing and encouraging to access them is going to be a big part of this. So with all of this in mind, the the Center for Adolescents and Transitional Urology came about. And our mission really is to improve the care of patients and families as they progress from pediatric to adult urologic care. And we aim to do this under 5 pillars. The first one is better education for parents about what the differences are, what that change entails, and better prepare them. The second thing is give them access to a healthcare provider, in this case, a nurse practitioner, for care coordination, care navigation, and at the same time, someone who is available to, that they can reach for semi-urgent things like prescription refills that, I couldn't make it to my family doctor, or I should have made it, but didn't. Investigations like I think I have a urinary tract infection, because otherwise they just end up in the emergency department. The third thing is we want to enhance our communication with adult care providers. And that's not just beyond the relationships that we already have, but timely, accurate transfers of health records. We know there's a lot to sift through. So an appropriate summary, for example, that is in front of every single transition document or package, a medical and a urologic one. The fourth thing is to seek partnerships. I've put so many specialties that already have clinics like this that are in full maturity, that are emerging. So there are like-minded services and programs that have this. And last but not least, through research, we don't know a lot about these patients when they graduate from pediatric care. And this is our opportunity to really find out. Central to the team will be the nurse practitioner with a primary care background. Dr. Anderson and I will take care of the urology if they come to VGH. The community urologist will take care of the urology when they're in their health authority. But really what we are not good at, I'll admit, are the basic things that we cannot ignore. As Dr. Patterson mentioned, there's a lot more than just having a urologist. And that that primary care NP is really the center, supported by a social worker, and of course the team at BC Children's, the urologists and nurse clinicians. What we want to do is change what the model is for transition in BC. On the top of the screen is what it is, I would say now or previously, pediatric care straight to adult urology. What we want to do is have a third box that patients can access in a predefined age group of 15 to 25. Again, making sure they keep track. They're on track for what they should be doing. So this clinic are for eligible patients age 15 to 25, as I mentioned, that require continued urologic care from the pediatric to adult system. We'll also invite those that have graduated but under 25 years of age, if they want to be part of this clinic and to access the resources. And what we foresee for urology, at least, is that majority of the patients will come from spina bifida population, posterior urethral valves, but we also have complex hypospadias patients, even the cystinuria patients that Dr. Patterson takes care of, right? And Dr. Forbes and Dr. Chu, where sometimes the non-compliance gene is right beside the gene for cystinuria. The ones that need encouragement, that you kind of have to be on top of, as you said, Dr. Patterson, to invest the time. Right? These are the patients exactly that I think will benefit the most. When they go through this time frame from, again, transition time frame, there's 3 distinct phases. One is the preparation phase, where from age 12, we start identifying them. Who are these patients that will need help? We're going to get them to have a family doctor. If they already have it with their parents, start engaging them. And with one of our nurse clinicians at BC Children's to really develop the soft skills that are required for independence. And as previous effort from BC Children's, the On Track kind of initiative, we're able to have resources for age-sensitive, developmentally appropriate, and youth-focused care for transition readiness, where they go into domains like self-advocacy, self-management, social supports, health and safety. And within each domain, there's a list of anywhere from 5 to 10 kind of goalposts to work on. And this is something that's meant to be done over time. We won't be able to achieve this within 5 years even. When they're closer to transferring to adult care, joint visits start happening with the transition clinic nurse practitioner, enable patients to build that rapport, build that trust, and to really show them that we are all on the same page with the same goal. We start preparing the transition documents for the primary care provider and any specialists involved in their care in the future. And we're going to identify who is the most appropriate urologist for this patient. And again, that we will encourage and we want them to get care closer to home for many reasons. Large part of it is really, can they travel? What are the resources they have? During the transition years, that's the 15 to 25 years age cohort, the NP will continue working with the patients to develop their skills for transition readiness. Again, it doesn't end when they're 17. The NP at the minimum will review patients annually to make sure they're on track. They're supposed to see the specialists they're seeing. Are they seeing their primary care provider? Are they on top of any investigations? So this is the piece that happens in the pediatric realm where someone is calling you and being on top of things. The NP is also accessible for, I mentioned, semi-urgent concerns. Like, I think I have a urinary tract infection. I lost an important refill for a prescription that I should be taking. I no-showed 2 times and I need a re-referral. And this is also a time where there's a lot of mental health crisis. A lot of it is really feeling overwhelmed, feeling like I can't cope. And the nurse practitioner will be, aided by a social worker, because in addition to providing counseling services, it's really the different disability tax forms. What are they eligible for? Right? A big part of it is, when they're in the pediatric system at the at-home program, catheters, for example, are just covered. There's no payment upfront. But when they graduate or they become adults over 18, they transition to, I think it's called the PWD program, where if their income qualifies, they have to pay for it upfront, and then they get reimbursed. And that could be a barrier in itself. And then Dr. Anderson and I will do joint clinics for the patients that we do keep in our healthcare authority that we need to see. We do this monthly as well. And with that, joint ORs, right, if needed. And the last phase is really the transfer phase. When they are 25 years plus, they are discharged from the clinic. That's why throughout this time, we really want them to maintain their care with their primary care provider and adult urologists, so that they're not just transitioning from 2 different places now instead of 1. The second thing is the clinic provides a resource for these patients and providers now for, I switched urologists, or I switched primary care provider, I switched another specialist. I actually don't, hopefully they don't say this, but can I get, I don't know what's been happening the last 25 years. Can I get up-to-date info on that? Hopefully that's more for the provider. And throughout this time, as they progress through the clinic, we need to know if we're doing well or not. Are we making a difference? First part of it is going to be measures of transition success. So every visit annually and semi-annually, when we see them for that preparation phase, they're administered the TRACK questionnaire, which is a non-disease specific validated tool that measures key skills needed by all adolescents to manage their own health. So domains are managing medications, tracking health issues as an example. And this is what's most commonly used in literature across specialties. Other things associated with successful transition is attendance with adult provider visits. Not just the first one, that's one of the key outcomes, but actually the subsequent ones. Are they making it to the recommendations? Are they getting their prescription refills on time? Are they compliant with things? And are they seeing their primary care provider? The other thing we track is, how is the clinic used? Tracking attendance of scheduled visits. Are they making it? And this is keeping in mind that there's going to, if they miss one, they're going to be called, right? And if they still miss that, then that's difficult. Regular inventory of unplanned patient visits. So what are they? Why are they reaching out? What was the outcome? Where would they have gone if we were not there? We want to compare it to the ones that we have invited back before the clinic started, and even the period immediately preceding transition, right? How was their health before and after? And then that also means following longitudinal variables, urologic and non-urologic. So hopefully it can help us ascertain, again, natural history of disease. What are the factors that impact their care? Is it geography? Is it socioeconomic factors? To what degree? And use that to guide us in how can we improve on things. Our long-term goals is number one, for the patients, for really this period surrounding transition to be something that is predictable, something that is normalized, is just expected, it will happen and we'll get through it, rather than the uncertainty that it currently is. We also want this clinic to be the model for something that is a province-wide transition to adult care initiative. And hopefully in a year's time, invite another service once we've ironed out the kinks. Right? That's also a way to make it sustainable. And the last thing is, amongst urology, at the minimum, is to kickstart a national research consortium of like-minded centers that are interested in this, that have already started to invest resources in this. I mentioned Toronto as one example. So we can better understand and manage these patients during the difficult time. And with that, 7:40, before I take questions, I'd like to thank a few important people and groups. First of all, it's the Ledcor group of companies and the Leddy family who have provided the funding for this. Dr. Goldenberg and the leadership at the US as well for getting the funding. Dr. McNeely and Dr. Afshar, who have really tried and been an instrumental part of this in getting this off the ground over the last decade. Questions?